Good morning, everyone. Good morning, everybody. Hi, and welcome to the PT on Ice Daily Show, brought to you by the Institute of Clinical Excellence. Happy Wednesday. This is Jerry on Ice. I am a TA within the Modern Management of the Older Adult Division in both the live and online settings with lead faculty Dustin Jones and Christina Previtt. Modern Management of the Older Adult Essential Foundations starts October 13th. You can catch us just about all over the U.S. come fall and then into next year, so head to ptonice.com to check it out. Disclaimer about today's episode. I'm going to be talking about depression within the older adult as well as late life suicide, which are particularly important yet sensitive topics. If this feels like a triggering conversation for you, if this feels like a triggering conversation for you, please feel free to hop off and join us another day. But it is a tough topic, and I am just so passionate that as providers who see our patients much more frequently than physicians and other medical providers, we need to have a really good understanding of what depression looks like, and in this population particularly, and then how we can be screening for it regularly. Let's start out with the definition. I think the word you're depressed, you're being depressed gets thrown around just a lot without a good understanding of what it actually means. Clinical depression is a mental health disorder characterized by persistently depressed mood or loss of interest in activities, causing significant impairment in daily life. Depression is common among older adults, but clinical depression is not a normal part of aging. Ageism does play a huge role here. People think depression and wanting to die is just a very normal part of the aging process, but let's continue to shout from the rooftops that this is in fact not true. Despite the physical problems older adults may encounter, most are actually very satisfied with their life. But we recognize that aging comes with loss. Aging comes with a great deal of loss. There is the loss of friends and family and loved ones, the loss of independence perhaps, the loss of the ability to drive, or the loss of functional capacity. Sleep is lost, social connection is lost, and that became very apparent during the pandemic, as well as loss of vision. Losing our vision has profound impacts on our mental health. This, plus the added stress of just not knowing how aging is going to look for them, loneliness, the burden of medical conditions, older adults are really at risk for experiencing depression. Now, depression can look a bit different in the older adults. It can be more of simple sadness, emptiness, apathy. I see a lot of patients that way when they don't, they're having trouble engaging with me or having trouble engaging in a home exercise program. And that's one sign that I'm starting to see that these patients might have symptoms of depression. There also might be feelings of hopelessness. This could be somebody who maybe is irritable or restless. They're very fatigued. They may talk or move more slowly. So I'm thinking about patients with dementia. Patients with dementia may have a lot of difficulty giving us information that they're depressed, right? They're not going to be outright maybe saying it. Maybe they're nonverbal, but they might be showing symptoms of irritability, restlessness, talking or moving more slowly. Patients may also report difficulty in sleeping. They might be eating more, eating less, or have difficulty concentrating. They may even mention wanting to die. It is not some super uncommon when working with older adults that they will offer up or give you an expiration date that they hope they're gone by Christmas. And we need to be aware that again is not normal behavior. We should also be aware that cultural differences may make depression look different. As in different cultures, moods, emotions are going to be presented differently. Patients may instead have a lot of physical symptoms, might have a lot of pain, aches, headaches, cramps, digestive problems. A lot of my own patients start presenting, like I said, with that apathy, disinterest, or maybe just a lot of pain on board, and that's starting to clue me in that something's up. Imagine how hard rehab is going to be if all of these symptoms or any of these symptoms are on board. Physical therapy, occupational therapy might be really, really challenging to actually see improvements because of all these barriers due to depression. Now think back to all of those symptoms and how many of your patients actually sound like that. For me, it's like 100%. 100% of my patients have some sadness, apathy, some have pain, some move or talk really slowly, some are eating a lot less than usual, they're very fatigued. These are like all of my patients. And even if they truly don't have clinical depression and they present with a lot of these symptoms, I need to be screening them. And my mission here today is to get you asking patients very simple questions during your course of care, not just evaluation day, to help determine next steps and catch depression early, because unfortunately, untreated depression can often lead to late life suicide. It should also be noted that older adults sometimes have suicidal wishes that can be in the absence of overt mental illnesses. And again, this is expected to grow during the COVID-19 pandemic. As the population ages, we are going to see the amount of late life suicide increasing. That's just a numbers game. In 2019, older adults accounted for nearly 20% of all suicides, with 71% of those suicides as a result of firearm use. This is a nearly a 60% increase in suicides in seniors during the last 20 years. Those are humongous numbers. There are systematic reviews suggesting that many of these older adults are actually different from young adults. They have less evidence of maladaptive personalities. They have less evidence for psychiatric diagnoses. They don't really meet the threshold for a psychiatric diagnosis, such as clinical depression. In this paper, which I will link, of course, on Facebook, older adults with pain, cancer, recent diagnosis of mild cognitive impairment, those with fear of dementia-related decline, fears of becoming a burden to others, older adults who refuse to go into nursing homes and loss of independence, have loss of independence, appear to be at the greatest risk for suicide. This article also talks about a few self-report suicide-related measures that you could add to your screening toolkit. So what can we do? First, we need to screen everyone. Everyone should get a depression screen. I don't see the harm in it. I don't see there being any true barriers to developing a relationship with somebody. These are just questions I want to know about them day one and continuing to know throughout the course of care. I use the Woolley depression screen. It is 2 questions. Question 1, during the past month, have you been bothered by feeling down, depressed, or hopeless? Yes or no? Question 2, during the past month, have you been bothered by little interest or pleasure in doing things? Yes or no? Very simple, can easily be put on intake paperwork, can easily be I don't even like it on intake paperwork as much as I like actually talking about it with them in person, because you would be surprised at the amount of people who actually just come out and say, oh yeah, like I have been feeling really badly about this, or I have found that I just don't want to engage in my social activities anymore. You would be really surprised how many people offer that information up. There's pretty good sensitivity on this test at 95%, meaning essentially a negative test will rule out depression. But again, in the context of the older adult, where we know that they're not going to meet thresholds for clinical depression or psychiatric diagnoses, we might need to be a little bit critical of those answers. And if somebody presents with symptoms of depression, still referring out to their PCP may be appropriate. The test also has 65% specificity when both answers are yes, so it's all right there. However, we can use all this information because we can only screen and then refer on to physicians and PCPs as necessary. Remember, we're not diagnosing depression, we are screening for it and then referring out. Second, we need to know more. We need to learn more. I don't think a 15-minute PT on Ice episode is probably going to cut it in terms of education about depression and suicide especially, because I don't remember learning a whole bunch about it in school either. If you have access to MedBridge, there is a good course called Suicide Care for Physical and Occupational Therapists that was worth a listen. It also came with a great PDF that you can print for your clinic that has tons of options for managing conversations around this. Like if somebody says this, do you say this? If somebody talks about a firearm that they have access to, then you talk them through that situation. It also has a ton of resources to get people help quickly. We need to be aware of signs and symptoms of depression and really not let these comments of suicide go unnoticed or ignored. It is super uncomfortable to hear from a lovely 80-year-old woman or man that offhand, they really hope to die soon. But we can't not lean into those conversations. We can't just go, okay, great, which I have done before. And we need to get a better sense of risk. Does this person have access to means? Are they truly wanting to perform this act? Do they have access to a firearm? That's really important for me to learn about when I walk into people's houses. Those are things I'd like to know. But we need to get a better sense of risk. Don't ignore those comments. We also need to understand our role in reporting emergencies and getting people the help they need quickly, especially if there's the active threat of suicide or self-harm, or if they're really looking for ways to do it. Remember that the National Suicide Prevention Lifeline number is 1-800-273-TALK. It's always a good number to have. We also need to make connections in the community. I need to know who in my community who as a social worker or therapist does home visits, because those people exist, who takes Medicare. A lot of therapists, turns out, don't even take insurance, but a lot of therapists don't really take Medicare as a primary insurance. So look at who does. And then who does telehealth? Because a lot of our patients now and during the pandemic can actually figure out how to do telehealth, can absolutely utilize that resource. Because here's the thing, I'm going to identify a ton of patients who need extra care, but the worst thing that you can do when somebody presents with depression in front of you and you're talking about it and you're getting through that is say, oh, next visit, I'm going to get you that name. I'll print that information out for you at next visit. You need to have that information there right now. You need to have that information in front of you, ready to give out right now. That's going to make sure that people get the solution that they need quickly, right? We don't want to let this linger anymore, and we don't want to anything bad to happen in the meantime. About 45% of people who committed suicide saw their primary care physician in the past month. So I would consider sometimes PTs are the primary care provider. We have a really big role to play here in making sure we're identifying people and getting them help they need quickly. Now, don't sleep on OT. This is a theme of all of my podcasts, is I don't want you to forget about the role of the occupational therapist. There was an interesting article came out in the beginning of August, talked about the role of low vision and mental health concerns and how occupational therapists actually add a ton of value in the space. Quoting from the article, occupational therapists have the training and scope to deliver both rehabilitative approaches aimed at addressing low vision outcomes and the corresponding psychosocial impact of low vision. OTs are amazing therapists to decrease functional disability, right, through all activities of daily living or IADLs. They work on decreasing social isolation by finding somebody transportation, finding groups in the area that someone can go to, or even just teaching them how to use a phone or computer better so that they can more meaningfully connect with people they love. They are also able to work on purposefulness and finding activities that bring people joy. Lean on OT, theme of all of my podcasts. Now, exercise is amazing. In the SEEDS study, SEEDS, antidepressants plus exercise showed a greater improvement in depression versus medication alone. I think a lot of us are on board with exercise working really well for depression. And a lot of studies actually indicate that aerobic, resistance, mind-body exercises really all do the trick. It's got to be something somebody enjoys. But remember, it's only a tool for depression. It's not going to fix everything. Don't wait to see if exercise is going to make a difference for folks. Make sure we're screening. Make sure you understand your limitations. You have those referrals ready to go. And so you can get patients the help that they need quickly. Remember that those articles will be linked on Facebook. I hope you all have a great rest of your Wednesday and a great rest of your week. Thanks.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.